We're going to start by talking about the state of nursing in 2026. We are secondly going to be talking about the areas that we've really been discussing with our CNE cabinet in terms of where nurse executives could or should place their strategic bets to really protect the long-term investments that have been placed in nursing. And then as you all well know, how the spending, et cetera, of health systems is changing, how to respond to some of the immediate cash crunches and really think about preparing nursing in the future, even and especially when that means additional investment. And then lastly, we want to talk about how Nursing Catalyst can support that work by sharing our 2026 research agenda and then also offering up some feedback on that front. Before we get into the nursing-centric piece, I really want to set the stage on health system finances in the spirit of giving us a common set of information to work off as we are thinking about investments explicitly. So when we think about the finance picture of last year, of course, so much more complex than the data that I have on this slide. But what the two data points that I would want to highlight as kind of the snapshot in time of 2025 are, first of all, that we are seeing operating margins. We started to see a shrinking of operating margins, the well-fought-for gains coming out of the pandemic that brought health systems a couple of years of sort of enhanced stability coming out of a period of a lot of red. We started to see those decline, but not necessarily as intensely as was believed over the course of 2025. And of course, as we start to get into H1 of last year, H2, we started to see those rise again. I think this is not to say necessarily that health systems are uniformly necessarily out of the woods when it comes to their margins. Yes, they're continuing to see recovery, but I would characterize that recovery as volatile, not one that felt as steady as the last couple of years. And then secondly, in terms of that recovery, we saw uneven distribution between much larger systems and much smaller systems. So again, even though we think of that, even as we are thinking about the margins themselves as being volatile, even when we're seeing sort of some positive returns and stability, a lot of that is really among health systems and hospitals in metro areas that really have had traditionally stable finances. And so even frankly, within larger systems, you're seeing, systems with a lot of resourcing, with a lot of stability, and those particularly in rural areas that we'll get at in a few minutes, who are really starting to struggle from a financial perspective or are continuing to see declines there. From a priorities perspective, and let me give you some context as to the data that's on this slide, the Academy actually collects priorities data from among folks within the system level C-suite year over year. So what you're seeing here on the slide in front of me is what folks said at the end of 2024 that were going to be their priorities across this year. As I'm looking on this, I mean, first of all, the thing that really stands out to me is that the core elements of strengthening the workforce are what is unusually high across the C-suite almost universally. I can't think of, for example, another time within the time that I've been at the Academy that CFOs have had strengthening the workforce, which we define to them as sort of those core workforce elements, retention, recruitment, et cetera, as being their number one priority. Now, I don't say that this is necessarily surprising per se. Again, it was somewhat novel in terms of the really uniform commitment to that. But you really, when you compare it to some of the other goals and that I've highlighted here, I think of the workforce sustainability piece as not only, of course, being important in and of itself, but really that the health system C-suites are looking at workforce as being the key enabler of everything else that they are really committed to. So, for example, I think one of the most obvious being access. We'll get into this in a few minutes later, but I think a really clear connection in the minds of folks between needing to commit to their workforce to really invest in bread and butter recruitment and retention as it relates to their growth goals in particular and where they're really going to need the workforce to shore up. But of course, I think you also see that workforce enablement piece coming in from an operational efficiency. I think, of course, folks not necessarily looking to strip back at the bedside support in terms of labor there, but really thinking about investing in the care delivery piece and thinking about how to reimagine care delivery in a way where labor costs are lower, but not necessarily from the perspective of stripping away resources. Before we get into 2026, I would love to hear from those of you on the line. Knowing that we have a rather large group today, have added a poll here so that you can share either by scanning this QR code here on the left-hand side or by going to slido.com within your browser and entering here. That being said, I know that we have some folks who are um, certainly willing to share their perspective. So also want to encourage you to unmute and share where you invested your time and energy in 2025, and whether you would say that was in line with some of the things that I just mentioned, workforce enablement, et cetera, and where it might have deviated. Mm. Yep, I'm seeing a lot connected to workforce. Would anyone want to unmute and share a little bit about where you were really digging in 2025? Of course, workforce, as it ought to be, I think is often at the number one or number two priority among nurse executives. And so I'm curious about what the flavor was or how you would characterize that investment across last year.
Lauren, I certainly can share what we've been working on at Ohio State. So, hi, everybody. I'm Corinne Steinhauer. I'm the Chief Nursing Officer at the James Comprehensive Cancer Center, which is part of Ohio State's medical center. So I put workforce and strategy. So we spent the better part of 2025 establishing our nursing enterprise strategic plan, of which one of the key components was building out an academic practice partnership
Mhm.
with our College of Nursing. And then really thinking about how we can convert more of our nursing students to our actual employees. So we have about 40%, 45, between 40-45% of our College of Nursing students actually are currently converting to OSU employees. So that was one component of, how do we increase that? The other thing is the College of Nursing has pretty big goals to grow. They are anticipating to double in size over the next 5 years, their graduating class. So currently, we graduate 176 nursing students every year. They want to graduate about 320.
Wow.
And so it's that symbiotic relationship about how can they tap into our master's and doctoral prepared nurses as clinical faculty, and then how do we capture more of their students and convert them into nurses. So that's
Yeah.
what we've been working on.
Absolutely. Well, doubling the pipeline is quite the goal. So really interesting to hear about that, and excited as we get into some of those conversations around readiness, confidence, and how to think about that as care models are changing as well. But Teresa, I see your hand raised as well.
Yeah, probably want to just tap on and do a bit of a shout out for the state of Arizona. I know there's a lot of people on the call today, so there may be others from Arizona, but Arizona has a grant called 1803. And one of the things that it's doing is, from a state perspective, is addressing the nursing shortage and looking at things like super preceptor, how we support rural health care. And Honor Health is leaning in really heavy in that space and have been awarded some of the funds and report regularly to the 1803 grant team. So we're on I think our second year of this. So I've been with the organization 10 months. So some of this I think does predate me for sure. But I like how the state is collaborating and looking at this with all the different schools, and how we can and help get new graduates into the workforce in a better fashion, and address that turnover that we are seeing. Even at Honor Health, we see turnover kind of in that 18-month, 2-year period of time where you're at risk of losing the staff as some of those new grad supports that kind of surround the individual are there, and then they pull back and then an individual gets overwhelmed. So I just want to do a bit of a shout out for that.
Absolutely. And great to hear not only about the investments that Arizona is making specifically, but also about how I think you, other health systems, academic stakeholders, et cetera, are really leaning in and thinking about all the different perspectives and sort of angles and expertise that are needed there. I'm going to keep us moving on for now, but certainly we will come back to these broader conversations and talk about where folks are leaning in for 2026. Of course, as we are thinking about trajectory 2026 and beyond, thinking about what happened over the course of 2025, I think the number one thing that is on the minds of not only the folks that we have on this line today, but also across, of course, your peers across the C-suite and beyond, is thinking about how the big beautiful bill is really going to and some of the other payment changes that are either within the bill or that are anticipated as future policy change are going to be impacting where health systems are looking. And so we won't focus on necessarily the details of what's in here, though, should you be curious about that, I'm happy to send those in follow-up. But suffice to say that I think not only is there a really pretty wide-scale financial impact on health systems, this being layered on top of some of the existing margin volatility that I was alluding to a few minutes ago, but there's also cuts in a couple of other places that are going to impact nursing specifically, but of course, patient care and health systems more broadly, including support for rural health, a lot to do with workforce pipelines, and, in sort of a general consequence of a lot of the changes here, a greater sense of operational uncertainty, both from a cost perspective, of course, of, how can we continue to keep the lights on and make sure that we are financially solvent even amid these changes, but really grappling with what's already in the bill and thinking about what next might come that health systems may have to respond to really quickly. Now, what I'm about to be sharing in the spirit of, again, giving a preview into investment and giving us all common data on which to reflect on where health executives and nursing leaders in particular may want to change their investments are the results of our financing and budgeting survey that the Academy does of VPs of finance and CFOs specifically. So you can hear all of these slides will be sent, by the way. I know that this is a lot of numbers all at once, but suffice to say that we talked to the finance leaders of about 40 large health systems and really asked them how they were thinking about changing, if at all, their investment strategy going into next year, which feels like a really helpful place to think about where nursing can take advantage of where the appetite for investment is going and where folks are going to have to be thoughtful and protective over some of those existing investments. The first thing that I would share, not necessarily related to the investment piece per se, although we'll get there, is above and beyond what I just mentioned on a policy front. What we are seeing is that inflation is already having an impact on health system finances, and I think has some really important implications as to how folks are thinking about their labor budget moving forward. So, for example, on the left-hand side of the slide, what you'll see is that the finance leaders that we spoke with have told us that they are seeing a decline in the number of days of cash that they have on hand, and that is a big priority for them moving forward. Again, especially with that volatility, needing to shore up those reserves is a huge priority for finance leaders. What this means for our conversation today is on the right-hand side of the screen, which is for the first time ever in the many years that we have done the finance and budgeting survey, almost half, a very large majority, you can see the pretty stark difference here between 2024 and 2025, are saying that they are anticipating their operating budget to decrease for the first time in a long time. That's not to say that, of course, there hasn't been significant attention to margin management overall. But I think, attention there or potentially thinking about that from the perspective of reducing the rate of growth of operating expense is quite starkly different from decreasing that overall piece of the pie. And so I think that's a really important data point for us to anchor on as we're thinking about that investment piece. Of course, in addition to inflation, in addition to kind of some of the more margin volatility, we're also seeing that some of the reforms, whether or not they were in the big beautiful bill or whether they're anticipated across the next couple of years, certainly occupying a lot of mind share for executives and particular finance executives. The number one concern being Medicaid reform, especially around the eligibility and work requirements. Again, We have a lot of folks in this room from a lot of different states, so I think that will look very different. I think that's even a lot of complexity for multi-state health systems to navigate. But seeing a lot of concern here on the federal policy perspective. And as we are talking to finance leaders around, hey, how much do you feel like you have this under your belt in terms of feeling equipped to be able to move through it? Seeing most individuals here in this light blue color feeling either just beginning or feeling not very prepared. So, a lot of work already being done on 340B pricing, more to come on Medicaid and some of the other subsidies. So I think concern, things that folks are starting to work on and plan, but a lot of uncertainty still in the air about how folks are going to be thinking about that investment in not only this year, but really especially across 2027 and 28. Now, as you think about the statistic that I mentioned earlier relating to the overall operating budget decreasing, I think the first thing that comes to mind for me is really about labor expenses and how that is really going to be squared, especially given the overall rise in compensation that we are seeing coming out of the pandemic. So as you look, what I have here on the left is labor expense as a percentage of the overall operating budget. We see, I would say, fairly steady, maybe a little bit of growth in terms of the amount of room and real estate that the labor budget is taking up. What I also know is that that percentage labor expense as a part of operating budget has a really strong impact on margins. So the bigger the piece of the pie, the more slim the operating margins tend to be for the health system. All to say, as we're thinking about decreasing the operating budget, labor is going to be a huge piece of that. What feels really hard from a labor perspective is a lot of the gains that health system had relative to labor around 2020, 2021, 2022. Those were all about reducing premium labor as the individuals on this line, as your peers across the country, we're really restabilizing the health systems and your workforce after the pandemic. So through those investments, both strategically and financially, in terms of your staffed employees, certainly seeing a lot of very expensive premium labor leave the workforce. I think what that means now is both good and bad news. Obviously, great news in terms of the ability to reduce those costs. And yet, what we're seeing is that the labor budget has not only reduced in terms of the staffing costs. You can see here, staffing is outweighing sort of premium labor in terms of immediate concern, but that there was a rise in compensation, not necessarily, I think something that made a lot of sense at the time and certainly was necessary to stabilize the workforce. And yet, I think that's going to feel very hard to untangle or to think about how to rebase labor expense in a way that feels financially stable moving forward. I would love to hear from the folks on this line in terms of your investments going into 2026. I'm just about to be able to share the data from finance leaders as to where are you looking in sort of discrete areas, workforce, AI, technologies, et cetera, where they are looking to both increase spend and decrease spend. And so I'm interested to hear from you all whether you want to share that in terms of finances or in terms of your own mind share and energy, where you're really turning the dial up in 2026. I'm seeing a lot on the technology perspective, and of course, we're going to get into that more later. Curious to hear either in the chat or if folks want to unmute what the concrete investments that they're making on the AI front are, or even evaluating if those haven't quite been purchased. Awesome. I'm seeing ambient documentation in here, virtual care models, anything else, and feel free also to share in the chat if easier, where you're thinking about those purchases or investments, especially from a tech or AI perspective. Yep. I'll share anecdotally as folks are continuing to share their responses here. I'm also seeing a lot of interest in sort of the preparedness piece around what's really necessary to get to the next step. For example, things like bolstering rover usage across the workforce as something for an enabler of ambient documentation, but certainly a lot of investment and thought being put in there. Yep, EMR integration in terms of AI as folks are really thinking about the ambient technologies in particular, both from a documentation perspective, but also more broadly than that. So let me share a couple of data points, again, in terms of where finance leaders are thinking about turning up the dial and turning down the dial in terms of spend. In terms of where folks are looking to increase their spend, what we're seeing is, not surprising, almost a 100% commitment to increasing spend on automation and AI technologies. Great news for everyone on the line who just said that they're interested in moving forward with AI or otherwise reevaluating that kind of automation. But I think also importantly, what you're seeing are a commitment, at least in terms of provider labor here, as you again think about that workforce enablement piece and the way that it connects to access. I think not surprising there, as well as potentially some concern and attention relating to some of the rising costs in supply chain that we've already been seeing. On the other hand, folks where leaders are anticipating a smaller budget, travel contract nurses, again, not surprising. I think there's probably less wiggle room there than there has been in years past, but certainly a good goal in terms of relative to the overall labor budget, as well as a reduction on administrative staff and sort of office space generally. I think the other good thing is we're thinking about moving and that investment in nursing as we break down where the workforce investments are going to be. I already mentioned that providers, advanced practice providers, as well as physicians, are areas in which health systems are anticipating dialing up their spend, but that also extends to RNs and other nursing staff as well. I think, again, we're seeing decline in travel, not surprising there. But I think the real risk, as you think about it from a nursing workforce perspective, is really what is at the bottom here, which are anticipated decreases in spending from administrative staff in particular. I think probably those who are really on the clinical front lines are relatively more protected, frontline managers, et cetera. But I think as we are having a conversation around what large-scale innovation will require, this might be where the rubber meets the road in terms of protecting that long-term investment. The last note that I'll make, and I think I'm interested to hear folks' perspectives on, and/or happy to share, what I've sort of been hearing in terms of how folks are responding to this, is the way that I think about it is really that the cavalry is not necessarily coming from an innovation perspective. And a lot of this work is really being squarely put on health system shoulders to advance. Outside of the big, beautiful bill, we're also seeing a large cuts to HRSA funding that really particularly impact rural pipelines in particular, but not exclusively. Cuts to workforce programs, cuts to the National Institute of Nursing Research, as well as, drops broadly in sort of NIH and HHS funding. I think as I've spoken to nursing leaders across the last month, somewhat despondent, thinking about these cuts and what that means for a lot of the work that you all are doing. What I've been really pleased to hear is that health systems are really investing in PhD programs. They're thinking about bringing on more nursing researchers, recommitting to magnet, et cetera, all of the places that are really moving nursing innovation forward. So I think that that's certainly going to continue. It really is just now more centered on sort of the individual health system versus sort of a broader federally subsidized movement forward in terms of research. So definitely something to think about, though a lot of health systems, I think, have really only reaffirmed their commitment to nursing innovation following this news. What I really want to spend the remainder of our time talking about today is really on what the play is as a nursing executive and what you all are thinking about in terms of, seeing these relatively volatile margins, anticipating some of the earlier cuts. Health systems are going to be looking for places in order to immediately decrease that operational spend. And what that really means in terms of implications for the nursing enterprise. And yet at the same time, all of you are going to be asked to think about how to think about those cuts in a way that ultimately preserves the long-term play of a nurse-led strategy to reduce total cost of care. I know that I certainly don't have to tell anyone this line that frontline leaders, clinical leaders, bedside nurses, those folks are so critical to a health system's ability to be able to maintain high quality, but also highly efficient care. And so I think that even when faced with the immediate task of, frankly, keeping the lights on when it comes to health system operations, how does one do that in a way that still preserves the momentum that folks have had coming out of the pandemic, coming out of the rebuilds and the reinvestment in the workforce that really precipitated? And how can we continue that momentum even while sort of juggling some of the near-term priorities? We, of course, have some early takes, but wanted to also invite you in as we go along to sort of share what you're thinking on these fronts and where you are putting those bets. The big term bet for us, knowing that folks have invested, again, a ton of funds, of investment, of mind share, of thinking into their workforce, is really to double down on an area that has felt hard and yet is uniquely more challenging today, as we can hear in some of the earlier conversations that we had around academic practice than ever before. So to really drive that home, I'm actually bringing on not academy data, but NSI's benchmarking around tenure-based retention. So what you see here are looking at turnover by different cuts of tenure, starting from 2021, which is where we're sort of seeing some of the highest turnover over years and years precipitated by the pandemic, and how that recovery has looked based on the tenure of nurses. So I'll just direct your attention first to some of the most tenured nurses here. And I think, again, you look at the 2 to 5 year range, 30% is hard to believe. But, certainly I think in 2021, that's when folks were feeling the greatest impact of some of the exodus of travel nursing, et cetera. What you see here is that among relatively tenured nurses, you saw a pretty steady decline thanks to all of the effort that everyone on the line today, as well as your nurse executive peers across the country, really put into their workforce, both from a literal investment and compensation piece, but also in terms of that reaffirmed commitment to addressing retention and really recruit folks in, as I know that many of you have done. Unfortunately, those gains weren't necessarily realized across. And so we're continuing to see elevated turnover is among the early tenured set, where not only have we not necessarily not seen a decline, but we're actually still seeing turnover increase, which is really interesting when you think about how a lot of the turnover here, where you're seeing 30%, 14%, a lot of that is really being pulled, by travel companies or by having that opportunity that the pandemic created, which is not necessarily the case as you're seeing nurses with less than 1 year even continuing to rise in terms of their turnover. So all that to say is we're thinking about short versus long-term efficiencies and where to find them in the workforce. This group of RNs, and I know that they're a pretty large group for most folks, is really where we would suggest that people are placing their bets. Now, this may be familiar to some folks who are on the line, but I think will be helpful to those of you who haven't yet seen this data. As I mentioned, in the last year, Nursing Catalyst worked with many of the systems that are on the line with us today to think about how to understand the issue of rising new grad turnover differently. Because what we know in the early 2000s is, of course, that folks really did think about it differently, invested in residency and transition to practice in a really new way, and one that has, at this point, now decades of outcomes to show that it reduces turnover. So our main question was, what is going on? We know those programs are effective. There's tons of information in the literature to that effect. Is there something more that's needed? Are they not meeting the need? How should folks really think about this differently? And how do we really understand the need of a new grad nurse today? What we found, in short, is what you see on the screen, which is as we asked new grad nurses about their self-reported intent to stay, we saw that those that said that they were more confident in their role were also the most likely to stay with an organization. And this is above and beyond clinical competence, which I know that many of the folks here, if you have residency programs, are already collecting with really considerable granularity, and of course are monitoring before folks are left out of are released from their onboarding. In my view, there's two gaps to close. First of all, that RNs can be developed more quickly from what is the major vulnerability zone, which is having low to mid confidence. And secondarily, that actually, as Teresa just mentioned a few minutes ago, we are seeing that folks have a post-residency cliff of clinical competence and a real area to target in terms of that vulnerability in a way that can realize some of those labor cost savings through reduced turnover. So I will quickly touch on why I think that is, and then would love to hear from the folks in this room as to sort of how that might be realized in your strategy. In our data, there's a pretty big drop off at this midway point. So in other words, you don't really have to be extremely confident to stay at an organization. Very confident is sufficient. Where you're in the danger of retention is between, not at all to moderately. And so one area is across that first year, how can we get folks, even if I'm not sure that you would even want a new grad coming in on day one is extremely confident, but in any case, how would you want to be able to move folks along? And secondarily, this is looking at that post-residency piece. Not only do we see that folks are overall losing confidence in their role as they are getting past the 12-month mark and are graduating from residencies, but they're also getting less confident on every specific clinical skill that we are really asking them about, or rather professional skill when it relates to nursing. And so there's clearly something going on in terms of what happens when you take away those supports. Theoretically, after a residency graduation, a nurse should be at their most confident, especially relative to those early days. And yet that's not necessarily what the data is indicating. And in fact, as we think about the labor cost piece of it, we also simultaneously see rising intent to leave as we are starting to track folks after graduation. I think this is a little bit more nuanced in the sense that, yes, these nurses could also be wrapping up their graduation and feeling ready for something new. And I certainly want to acknowledge that as a possibility. And yet, I think getting at the confidence piece, understanding why folks want to or are really thinking about their role as nurses. I think there's a socialization component in addition to the clinical competence. That part feels increasingly important to crack to really continue to make those reductions in labor costs relating to turnover. I would love to hear from the folks on this line. I know that Corinne and Teresa shared a little bit around what they were doing on the academic partnership side, but I know that early tenure turnover is something that's top of mind for many folks here. So I'm curious about where you all are spending your literal or figurative pennies relating to early tenure turnover, especially because this has been such a pressing challenge for so long. I'm curious about what you might be trying to do differently in the future. I see that folks are typing in the Slido, but you're also welcome to unmute yourself and share live if there's anything that feels easier to share that way. Mhm. One thing I'm struck by, recognizing that many of you are still typing, is that a lot of the places where you're looking to focus some of that early tenure retention is around the mentorship and connection piece in particular to their unit. One thing that really reaffirms that, and we've been having discussions about in other conversations around this data, is around what a good mentor is, and how that might be changing in relating to what early tenure nurses need. So, for example, one CNE that we were speaking with shared that, she had really thought about mentorship as being this really official role, someone, a leader on the unit, who is really well recognized. And thinking about how the feedback she had gotten from early tenure staff was actually that they kind of want the opposite. They want someone who's more of a peer, more of a friend, someone with whom they almost have a more casual relationship, and frankly, someone who might even be outside their unit and for whom they can be a safe space to be able to confide about their insecurities in practice, the dynamics on the unit. And so I think thinking about not necessarily where to make net more investments, but really how to adjust the programs relative to how the changing needs are of new graduate nurses is something interesting to think about. Douglas, I also saw, not to put you on the spot, that you made a note of stress management and resilience training, and I'm also seeing folks talk about reaffirming their commitment and investment into well-being. So curious if either you, Douglas, or someone else on the line wants to share more about the well-being investments in particular.
Lauren, all that I can say is the SMART program, or stress management and resilience training, is a carve out. It's been developed and it's been studied and it's been shown to result in greater retention because it not only focuses on the stressors of the day-to-day job, but it also focuses on those stressors in everyday life, which also sometimes plays into a decision to leave.
Yeah. Absolutely. I think that's really interesting and really thinking about the confidence piece in particular as being something above and beyond actual clinical skills, but more around how do you navigate the environment and how do you navigate the professional experience of being a nurse. So thank you for sharing and really exciting to hear about the work that you have ongoing. I'm going to keep us moving in the spirit of getting to the second half of our conversation around AI in particular and some of the care model redesign before we close out across the next 15 minutes. I think something just worth making note of, but certainly something that every nurse executive on this line is very committed to. As you're thinking about the tangle of the fixed labor costs, continued turnover that we just talked about, and related to that turnover, kind of an exodus that folks are seeing away from bedside care. What that really points to is the need to transform the way that care is being done. And of course, as we're getting this sort of enhanced notion of reduced operating budget and the enablement around technology in particular, thinking about what does this look like and really where does technology play a role. So I'm going to share a couple of data points similarly to our finance survey, but rather this is coming from clinical leaders in terms of where they are placing their bets on technologies and on care model redesign in the future to sort of give you a sense of where folks have already been focused. So in particular, as we narrowed our data set to just look at chief nursing executives, where we are seeing to date is that a lot of that focus has really been around virtual nursing and flexible scheduling models in particular. This data was collected last year, so you see AI-assisted documentation and workflow ambient listening there at the bottom at 20%. If I were to guess, even among this room, if we were to poll folks and say, hey, have you either done this or are you actively in sort of those talks, that would be a great deal higher. But I do think that this is what we are likely seeing is sort of a continuation and a maturity of where folks are then and where they might be going now. We'll skip past this as a question just because we talked about it a little bit earlier, but certainly want to come back to that at the end. I think the interesting thing that the interesting moment in time as you're thinking about technology, but I also think is a helpful reframe as folks are imagining how to bring their workforce along with them is historically, technology has not necessarily meant gains in the workforce or in terms of increased productivity. Of the folks that we've been talking about with ambient documentation, as exciting as it is, I think it almost conjures up this spirit of thinking about an EHR go live, what that was like initially, in the 90s and early 2000s, and thinking about doing that over again, because there are a lot of advantages to, electronic records, certainly. They're enabling all of the automations that are going on now at a minimum and have certainly had a lot of other benefits. And yet you don't really think of them as being workforce satisfiers or things that really enhance the productivity of bedside staff, including nurses, but also including, anyone who really work with them. And I think this is an interesting paradigm to talk about because not only has it really completely flipped, as you saw in the earlier slides around where finance leaders are looking to increase their spend, but I think this also is going to be challenging from a nurse executive perspective in terms of how do we get our staff to be excited about, be on board with the changes that are going to come and will definitely impact their workflow in a way that sort of speak to this historical relationship that technology has had on productivity, e.g. not increasing productivity, while still bringing people along and making them feel really energized from that work. As you can imagine, a huge part of this relationship that's changing with technology and productivity is, of course, AI. As we are looking across the C-suite, not only from a spend perspective, but also in terms of increase of mind share, you're seeing that almost all the executives whom we surveyed said, yes, AI is a much bigger priority for me heading into this year and going into 2026 than it has been historically. I think interest, of course, not surprising here on the informatics perspective, but what I love to see is that it's really clinical leaders who are at the forefront of thinking where AI could and should be integrated within the health system and where it's really prized to make an innovation. And I think the one thing that I would talk about within that, and I think is really helpful to bring up from a nursing perspective, often folks are thinking about AI, and rightfully so, is thinking about where it is reducing work for the workforce, whether that's really from an efficiency perspective, e.g., we either need less staff or we are able to do things that we just simply do not have the staff to do. And as it should be, especially as you think about that cost perspective and the fixed labor cost issue in particular. What I think is really interesting, above and beyond the really direct ROI from an efficiency standpoint, is thinking about where nurse executives want to invest in a way that is actually a differentiator in terms of workforce strategy overall, not necessarily related to a cut and dried piece of ROI. So I'll give you an example for physicians that I think is soon, if not already, going to be true for nurses. And that is around the role that we've seen ambient listening play as inside traditionally physician ambulatory clinics. So as I'm sure is true of many of your health systems, our data shows that investments here in voice-to-text technology, in ambient sensors for physician documentation are frankly nearly ubiquitous at this point. Again, I think if we could re-poll, this was only done maybe 4 or 5 months ago, if we re-polled people now, we'd see probably uptick into 70%, 80%. And not only is this, yes, an efficiency play, we're seeing less pajama time for physicians. We're seeing that folks are increasing their productivity. But if you look at the right-hand side, what's making CFOs and the clinical leaders excited is that it is truly a workforce recruitment differentiator. Their physicians are saying, as I've had these conversations in person with physician leaders, that they literally cannot get doctors to to work at their clinics unless they are able to have these technologies. And so I think, extra advantage of being and making these investments early and really committing to experimentation on this front is not necessarily just the efficiency gains and the cost savings that will play out across 2026 and 2027, but really about getting that leading differentiating edge in the market for technologies that we know that folks want to work with. And I think that question and that interplay is really top of mind for the nurse executives who I think probably comprise everyone in this room who are thinking about when is the right time to make these investments in ambient nursing documentation, which of course is starting to come to the forefront. The last thing I want to talk about, because we've talked about when folks are making the immediate purchases relative to care transformation. And I think that there's a lot of things at play on workforce readiness, on the technology enablement. How do you get rooms ready? Do you have rober access available to your nurses? So regardless of when the go live date actually is, I think there's going to be a lot of variation there. And yet there's a lot that folks can do now in 2026 to prime their workforce for this tech-enabled care transformation that we know that not only the nurse executives on this line, but your C-suites and your CFOs are really expecting. And I want to talk about that as we close out. By the way, as I mentioned, I'm about to launch a poll so that you all can provide feedback on today's session. You'll see that pop up. But please do feel free to continue to be on the line with us as we close out at 2 o'clock. Now, the last note I want to end on is around how your workforce is really thinking about these technologies and what everyone can do, regardless of what the timeline looks like for your system, in order to prepare folks for, I think, the inevitable but hopefully exciting changes that are coming to their actual workflows. The first thing I'd mention is that as we surveyed nurses on how they're feeling about AI on virtual nursing, what we are seeing is, to put it mildly, they are not so confident that these technologies are going to provide a positive benefit to their organization's ability to maintain safe staffing, to that kind of labor stability and core issue of workforce peace. And at the same time, I think it's equally as important to say that as we did message testing work with frontline nurses, we actually saw these, we were able to make a noticeable difference into folks' receptivity of using these technologies. So yes, not a great deal of enthusiasm organically, but I think with a small amount of concerted effort, folks are able to get to, if not 100% in terms of excitement, then at least significantly move the dial by virtue of 20 and 25 points. And so as you think about where you are spending your time as a nursing executive above and beyond when the go live dates of these technologies are happening, or what feels appropriate in the sense of your system, my one push of 2 is to think about how you can start to correct the record on some of the things that RNs are concerned about relative to these technologies that I think will almost certainly be ubiquitous in the way that folks practice. And that includes thinking about addressing the workload piece and getting ahead of that, but really, most importantly, sharing narratives around how these technologies are really improving patient quality and experience. I know that folks, of course, if you're introducing these technologies, are really laser focused on those outcomes. And I think sharing how systems are tracking them sharing system commitments to patient quality and experience, even among these technologies being integrated, is critically important for down the road when ready, that staff are really receptive and excited to use them, and that they will result in the kind of workforce savings that you're looking for. And the last thing that I would mention is on our new work relative to early tenure practice. What we are seeing is that even folks are graduating out of their residency programs, which makes complete sense, given that these programs were designed in often the early 2000s or, maybe updated every couple of years, that they're not necessarily addressing the skills that new grads need to feel confident in working in these models of care. So, for example, even though we see that of the systems that we worked with on the benchmarking, roughly between 70 and 80% of them are already using AI, are already using virtual technologies. Only 17% and 25% of their new grad nurses are highly confident in leveraging AI and virtual nursing skills. Skills like explaining AI to patients, collaborating with virtual nurses, delegating tasks, and understanding how AI functions in clinical care. And I would encourage folks, again, no matter when you are concretely thinking about introducing these technologies, now is truly the time to pull forward those conversations with academic partners on, how we are preparing our nurses to do this in the future. So knowing that we just have a quick 60 seconds left, I want to make a shameless plug for the remainder of the year. We are doing a whole bunch of work on this front, post-residency turnover, clinical competency activation. We're going to be redoing a lot of our work on span of control now that folks have really had some time to rethink about their frontline management role, all in the spirit of helping you identify and address those near-term financial opportunities for nursing in a way that really preserves nursing's long-term ability to inflect cost of care. I'll be sending out a link to register for these sessions across the first half of this year, much more to come on the second half. But really excited to welcome you to many of those sessions and to continue this dialogue in more concrete terms on where folks are making real changes in a way that not only, yes, does make those necessary cuts, but really enhances the quality and experience of nurses at the bedside. So with that, we've officially hit 2 p.m. and certainly don't want to keep you any longer. Have a great rest of your afternoon. It was wonderful to see you all and really excited to welcome you to our events across 2026.